Welcome back to Al-Biruni official YouTube channel. In today's video, we'll discuss a very important topic. In this session we will explore the spine-explained anatomy, spinal cord, disc herniation and spinal stenosis. This lecture is delivered by our esteemed faculty member, Dr. Rahila Soomro, who brings extensive expertise and experience to guide us through the topic. By the end of this unit, you will not only develop a comprehensive understanding of spinal structure, function, and common pathologies, but also gain valuable insights into teaching approaches, learning styles, and their practical applications for enhancing patient education and clinical practice. Do not skip any segment of this video, as every part contains valuable information. Also, you'll find the proposed BCQs from this lecture in the description section below. Make sure to check them out for your learning and exam preparation. So, let's begin. Structure of the spine. The spine is divided into two main functional components. The anterior pillar, consisting of the vertebral bodies and intervertebral discs, serves as the hydraulic, weight-bearing, and shock-absorbing portion of the spinal column. In contrast, the posterior pillar, also known as the vertebral arch, is made up of the articular processes and facet joints. These provide a gliding mechanism for movement, while the transverse and spinous processes act as attachment points for muscles, giving the spine stability and controlled motion. Motion of the spine. Spinal motion can be described globally or at the functional unit, also called the motion segment. This unit is made up of two vertebrae, the intervertebral disc, and the facet joints, with the axis of motion typically lying in the nucleus pulposus of the disc. Motion occurs in different planes. In the sagittal plane we observe flexion and extension, in the transverse plane rotation, and in the frontal plane lateral bending. Additional forces include lateral shear, where the upper vertebra shifts sideways, and compression or distraction, where the vertebrae approximate or separate vertically. Together, these movements give the spine 6 degrees of freedom. Intervertebral disc and foramina. The intervertebral disc plays a central role in spinal mobility and stability. It is composed of the annulus fibrosus, a series of concentric collagen layers that resist motion, and the nucleus pulposus, a gelatinous center that distributes pressure evenly. Together with the facet joints, the disc forms a three-joint complex between adjacent vertebrae. The intervertebral foramina are small openings that serve as passageways for spinal nerves. These foramina are bounded by the disc in front, facet joints at the back, and pedicles above and below. Pathology of the intervertebral disc. Disc pathology is common and may present in several forms. A protrusion occurs when the disc bulges outward but remains contained. A prolapse indicates rupture of the nucleus into the spinal canal. An extrusion occurs when nuclear material extends beyond the disc space, and sequestration refers to the complete separation of disc fragments. Such conditions often result in pain, abnormal posture, neurological symptoms, and reduced mobility. Imaging may reveal degenerative disc disease, bulging or herniated discs, or thinning discs. Other spinal pathologies. Additional spinal pathologies include postural stress, abnormal posture, muscle strain or tear, degenerative disc and joint disease, rheumatoid arthritis, nerve root lesions, spinal stenosis, instability, spondylolisthesis, and compression fractures. Disc facet joint relationship. The disc and facet joints together form a three-joint complex. Any injury or degeneration in the disc alters spinal mechanics, leading to abnormal stress on the facet joints, cartilage degeneration, narrowing of the spinal canal, instability, and muscle spasm. Segmental instability occurs when control within the neutral zone of movement is lost, while spinal stenosis refers to narrowing of the spinal canal, often caused by disc protrusion, osteophyte formation, or ligament thickening. Symptoms of stenosis are commonly aggravated by spinal extension. Facet joint pathology. Facet joints are synovial articulations enclosed in capsules and supported by ligaments. Like other joints, they may be affected by arthritis, trauma, or inflammation. Pain may arise from entrapment of fat pads or synovial tissue, or from degeneration and swelling. Impairments include localized pain, hypomobility, altered posture, reduced extension, or hypermobility in early stages of degeneration. Concept of spinal stability. Spinal stability is best explained as a three-legged stool, where the passive system of ligaments and bones, the active system of muscles, and the neural control system must all work together. Instability develops when any one of these fails. Motion of the spine is also divided into zones. The neutral zone, where minimal resistance is encountered, the elastic zone, where resistance increases as tissues stretch, and the plastic zone, where excessive movement leads to tissue damage. Muscle and soft tissue pathologies. Muscles and surrounding soft tissues are also prone to injury such as strain, tear, or contusion. In the acute stage, patients often experience pain and difficulty with daily activities, while in the chronic stage there may be adhesions, reduced spinal control, impaired postural awareness, and difficulty with repetitive or sustained movements. Principles of management. Management begins with careful assessment, patient education, and reassurance. While most acute injuries resolve within a month, severe cases involving the spinal cord or nerve roots may result in paralysis, sensory loss, or weakness. Rehabilitation emphasizes posture correction, core stabilization, safe movement strategies, and gradual progression of activities. Modalities such as massage, traction, or manipulation may be added when appropriate. Patients are encouraged to remain active rather than resting for prolonged periods. Movement biases in patients. Patients often present with characteristic movement patterns or biases. Inflection bias, commonly seen in spondylosis or spinal stenosis, patients gain relief with forward bending, and management includes flexion-based exercises and positioning. In extension bias, usually linked with disc lesions or flexion injuries, patients respond better to extension-based movements such as those used in the McKenzie method. Some patients demonstrate a non-weight-bearing bias, meaning they cannot tolerate either flexion or extension, and may initially benefit from traction or aquatic therapy until weight-bearing becomes possible. Stabilization training is important for those with instability or hypermobility, while mobilization and manipulation can be helpful for selected cases of acute low back pain. Temporomandibular joint dysfunction. The temporomandibular joint, or TMJ, is closely linked to cervical spine posture and function. Dysfunction may present as local pain, muscle spasm, or referred symptoms in the ear and neck. Common causes include joint inflammation, subluxation, poor posture, or muscle imbalance. Management strategies focus on pain reduction using relaxation and massage techniques, adoption of a soft food diet, and exercises designed to improve proprioception and muscular control, such as gentle tongue positioning exercises against the palate. Thank you for watching. If you found this video helpful, don't forget to like, share, and subscribe to Al-Biruni official YouTube channel for more informative health and medical education videos. And if you have any questions or queries related to today's topic, feel free to write them in the comment section below. I'll personally try my best to answer each one of them. Remember, knowledge shared is knowledge multiplied. Stay curious, stay updated, and keep learning.